Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Easy Medical Notes, which is the summary of standard medical textbooks like Harrison, Davidson, McMaster, Oxford Pocket Medicine. Myself, Dr. Rais Khan. Previously, we have discussed about the other cardinal symptom of pulmonary system, that is breathlessness or dyspnea. And we have completed the definition, pathophysiology, causes and clinical features, and in brief investigations of those diseases. Uh, Now we will discuss about the investigations and treatment in general, and in brief uh, treatment of some specific common disorders. Now firstly we will revise about yesterday's, summarize briefly yesterday's topic, not all. So yesterday we have seen that the main classification is the dividing dyspnea into two, as acute and chronic. Acute breathlessness is something based on the time of onset. We can classify it as from minutes to hours to days, or breathlessness at rest, that is known as acute breathlessness. So we have also discussed that whenever a patient comes with uh, uh, acute breathlessness, then we should rule out airway obstruction first, then anaphylaxis. Third is pneumothorax. Airway obstruction, there will be history commonly seen in children, like foreign body inhalation. In anaphylaxis, there will be history of allergy. Along with that, there can be urticarial rash and intake of some drug or something which cause anaphylaxis to the patient. In pneumothorax, there'll be, if the pneumothorax is one side, then there'll be unilateral 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 silent chest, silent hyperresonant chest. This will be the finding in case of unilateral pneumothorax. Unilateral meaning one side, silent meaning there will be no breath sounds at that side. Hyper resonant meaning when you percuss the area, then uh, it will be hyper resonant. So unilateral silent, no breath sounds with hyper resonant chest indicates pneumothorax. If you order a chest X-ray, then you can see uh, uh, hypertranslucency. Suppose this is the trachea and this is the lung, and the pneumothorax is at the left side, and this is the chest wall. You will see the hypertranslucency of the chest. It will hypertranslucency of the chest, and you will see the contracted border of the lung. This is the lung, this is the chest wall. Contracted border of the lung, and between the chest wall and the lung there will be hypertranslucency. So based upon this, if this is less than 2 centimeter, so in pneumothorax in chest X-ray, this is the lung, this is the chest wall, this is the distance between the lung margin and chest wall. If this is more than 2 centimeter, it is called as large pneumothorax. If it is less than 2 centimeter, then it is called as small pneumothorax. These two uh, uh, will resolve on their own. Just these two will require oxygen therapy, and treatment of the cause. Treatment of the cause. There is one more. So based upon, so there is one large pneumothorax and small pneumothorax. So those require only oxygen therapy for some days, and treatment of the cause. Third one is the life-threatening cause, that is spontaneous, sorry, tension pneumothorax. Tension pneumothorax. Here, here, the pathology of this will be where there is means the broken wall of the chest will act as a single means single valve mechanism, meaning if the air will come inside, this will become like this, the chest wall piece, the air will become inside, but when when the air tries to go outside, this will lock, like this will lock like this, and air gets blocked here. So continuously there will be accumulation of air in the pleural cavity, that is termed as spontaneous pneumothorax. So you will have again these unilateral signs. Along with that, you can also have decreased you can also have hypotension and tachycardia, similar to pericardial massive pericardial effusion, hypotension and tachycardia. So in this case, immediately you should insert a large IV catheter into the second interstitial space in the mid clavicular line immediately, so that immediately uh, the large air which is trapped inside comes outside. You can borrow some time. Thereafter, you can insert the intercostal tube, then that is connected to water, and then after some days, the tube when the tube for 24 hours, actually for 24 hours, if the tube doesn't show any bubbling, then you can remove the intercostal ICD tube. That's about the three pneumothorax. So next causes you should consider are pulmonary edema. So important, there will be history of cardiac history, and orthopnea is a very important history in case of acute pulmonary edema. There will be bilateral basal crackles at the back of chest. They can be raised GVP. On X-ray you will have cardiomegaly and pleural effusions also in pulmonary edema. And on ECG you can have, it can show ischemia or arrhythmia or only sinus tachycardia. Next common is massive pulmonary embolism. So there will be risk factors. What are the risk factors? There will be a history of immobilization, and there will be history of recent hospitalization of the patient, and history of syncope and dizziness and pleuritic lateral side chest pain will be there. Important findings in examination are, there will be increased JVP and absence of the signs in lung in spite of increased JVP, and there will be shock. Oligemic lung fields, meaning decreased blood flow to the lung, and ECG, most of the time ECG shows only sinus tachycardia or RBBB pattern and increased T waves in from V1 to V4. This S1 Q3 T3 pattern is rare. So these are the cardiac causes. Next are acute severe asthma. So there will be history of wheeze, history of allergy and asthma medication. So here JVP will be normal. JVP will be normal, and there will be wheeze on auscultation. decreased peak expiratory flow if you measure by peak expiratory flow meter, and in severe cases of asthma you will also have pulsus paradoxus. So the discriminating feature are normal GVP and with wheeze. Normal GVP with wheeze. Wheeze is also seen in cardiac asthma, but here the JVP is normal and there is wheeze, so it is asthma. On chest X-ray, you will have hyperinflation unless it is complicated by pneumothorax, and sinus tachycardia in ECG. So these three are the main investigation in acute cause of breathlessness. The second common cause, pulmonary cause, is acute exacerbation of CD. Smoking history is the very important history, and the previous history of exacerbations. Chest will be hyperinflated. Chest will be barrel shaped chest will be there, and there will be flapping tremor and bounding pulse. These are the descriptive features. These are the signs of carbon dioxide retention. On chest X-ray, you will see hyperinflation because it is obstructive pulmonary disease, and you can also see some bullae. It can be complicated by pneumothorax. And on ECG can be normal, or there can be signs of right ventricular strain. What is right ventricular strain in V1 and V2? In V1 and V2, normally the R wave is small and S wave is like this. V2, this will go on increasing, S wave will go on decreasing. V3, it will become biphasic. V4, S wave will decrease like that. But when there is right ventricular strain pattern, particularly in case of pulmonary nothing but heart failure due to pulmonary cause. So you will see in V1 and V2 particularly, there will be R wave more than S wave. R wave amplitude more than S wave, along with inverted T wave. Inverted T wave. Inverted T wave. R wave more than S wave, along with inverted T wave. And one more important point about this inverted T wave is these two limbs will not be symmetrical. See, this is sloping and this is this is sloping and this is somewhat straight. So that represents right ventricular strain pattern. Along with this, you can also see right axis deviation, meaning left leaves one will be positive, lead two will be negative. So this will be the left. There will be right reaches pattern. In one, predominantly negative, into predominantly positive. So this will be right axis deviation along with right angle pattern. If these two limbs are symmetrical, then that suggests ischemia or a minor MI. It can suggest if these two limbs of the T wave are symmetrical. Okay. Then pneumonia. There will be history of fever, chills, pleuritic pain. What is pleuritic pain? When patient inhales, there will be catch in the respiration, and that catch will not be there in expiration. Catchy type of pain will be there whenever the patient inspires. That is pleuritic pain. And there will be in signs there will be fever, pleural rub, consolidation. This consolidation is also seen. These features are also seen in uh, pulmonary infarction also. But the slight fever can be there, but there will be no history of uh, uh, chills or prodromal viral illness like that. So same history will be there with pleuritic pain along with consolidation in pulmonary infarction. So chest X-ray will show pneumonic consolidation, and ECG will show tachycardia. In metabolic causes, there will be evidence of diabetes or renal or aspirin or some poisoning. Okay. Important sign is there will be no heart or lung signs, but there will be dehydration or air hunger. And remember, there is SpO2 will be normal in spite of tachypnea. SpO2 will be normal, and there will be dehydration. Next, psychogenic cause. In the previous episodes, there will be history of digital and perioral dysesthesia. No cyanosis, no heart or lung signs. There can be history of carpopedal spasm because of transient hypocalcemia which occurs due to hyperventilation during the panic attack. Chest X-ray will be normal. PaO2 will show decreased carbon dioxide because of hyperventilation and decreased H plus ion. Okay, that's about the acute causes of breathlessness. You should go like this only. First, you should rule out those three causes, then cardiovascular cause, then pulmonary cause, then metabolic cause, then psychogenic cause. Now coming to the chronic causes. Summary of chronic causes. Chronic causes, respiratory causes include COPD. Patient will have history of smoking, previous exacerbation. On chest X-ray, there will be hyperinflation. There can be belay. Okay. On ECG, there can be right ventricular state pattern, as we have learned. In asthma, there will be history of allergy, previous exacerbations. On chest X-ray, there can be hyperinflation, and on ECG, there can be tachycardia. Interstitial lung disease, there will be history of persistent cough, and one exertional. All causes of chronic breathlessness will have exertional dyspnea, chronic exertional dyspnea, chronic exertional dyspnea. Okay, so there will be history of chronic exertional dyspnea and all this. In ILD, there will be history of cough also, and if you auscultate, you can hear inspiratory and inspiratory creps, along with finger clubbing will be present. Clubbing of the fingers will be present. In lung cancer, there can be history of hemoptysis, and patient can be cachectic. There will be history of chronic smoking. On chest X-ray, you can see a uh, opaque circular mass with corrugated border on chest X-ray. You can confirm this with HRCT. Okay, coming to the cardiovascular causes. Chronic heart failure. So chronic heart failure either due to ischemia or due to cardiomyopathy. There will be raised GVP. There will be history of bilateral pedal edema. Okay, bilateral pedal edema. And whenever there is acute exacerbation of this chronic heart failure, there will be pink frothy sputum along with breathlessness, and increased pedal edema, increased JVP, and bilateral creps will be there. JVP will be raised, bilateral pedal edema, and bilateral creps. So these are the sign of. In some patient who have very mild heart failure, you can exclude this one. Oxford says most of the patients who are taking drugs for hypertension, they will have thiazide in their drugs. So to rule out this chronic heart failure, those patients who are not on diuretics, and you should just say to walk in the corridor. After walking in the corridor, if we are auscultating bilateral crackles and those patients are not on any diuretics, then suspect chronic heart failure. Confirm it by 2D echo. Next is constrictive pericarditis or cardiac tamponade. These are also causes of chronic breathlessness. Constrictive pericarditis, I have already discussed. Classical example is post-tubercular effusion, and other causes are acute viral pericarditis, which can also lead to effusion, pericardial effusion. Pericarditis, what will be the uh, sign? So there will be QRS. There will be ST segment elevation concave upwards in almost all of the leads. Almost all of the leads. In MI, there will be concave upwards ST elevation, but restricted to inferior leads or lateral leads or anterior leads, like that. But in pericarditis, this will be the picture in almost all of the leads. And in acute pericarditis, patient will be young. Typically patient will be young, and there will be history of cold, prodromal history of cold. Okay, viral pericarditis. And whenever there is massive massive pleural effusion causing cardiac tamponade, you diffuse decrease of the amplitude of QRS complex, you will see diffuse decrease of amplitude of QRS complex, you will see in the ECG. Along with that, there is some sign called as electrical alternance, where one QRS will be long, will be short, one will be long, one will be short, one will be long, one will be short, or it can be like this: one will be positive, one will be negative, one will be positive, one will be negative. This is called as electrical alternates, and it occurs because of the to and fro motion of the heart in the fluid. When the heart moves towards the lead, it becomes positive. When the heart moves away from the lead, it becomes negative. So that's why there is electrical alternance in that. Next, pulmonary hypertension. So any cardiac disease like a COPD or asthma or chronic pulmonary thromboembolism, which is there here, so it can cause pulmonary hypertension. Pulmonary hypertension, on auscultation, on history, you will have history of exertional breathlessness. Along with that, on auscultation, you can have ejection systolic murmur in the pulmonary area. Ejection systolic murmur will be there in the pulmonary area. And in if patient progresses, and if there is right ventricular hypertrophy, then patient can also have pedal edema, bilateral pedal edema. And on chest X-ray, you can have cardiomegaly. Chest X-ray, you can have cardiomegaly because of right ventricular hypertrophy. And on ECG, you will have uh, right ventricular hypertrophy, meaning V1 and VT will show R wave more than S wave, R1 more than S1, and there will be right axis deviation in 1 and 2. Right axis deviation means 1 predominantly negative and 2 predominantly positive. Along with that, you can also see right bundle branch block, and along with that, you can also see P pulmonale. So remember this one. Suppose this is V1, there will be P pulmonale, and there will be R more than S in V1. And if there is strain pattern, T wave will be inverted, the limbs will be asymmetrical. So this is the classical graphical pattern which you can see in right ventricular hypertrophy. P wave will be more than 2.5 small squares, 2.5 small square high in height. T wave will be inverted, R will be more than S in V wave. Okay, and this also suggests enlargement of the right atria. And also in V1, actually it is biphasic, so R will be more and the next phase will be less. like this one. In V1, this will be more and this will become less. Actually, it is biphasic, but when there is right atrial hypertrophy, it will be like this. And then, if there is a right bundle branch block also, R, S, R dash pattern along with inverted T wave, R, S, R dash pattern, and this is P pulmonale. This is the thing which you will see in pulmonary hypertension. Okay. Metabolic causes: severe anemia. Patient will have history of easy fatigability, easy easy fatigue, or generalized generalized weakness. And on examination, they'll be paler. Okay. And obesity is the next metabolic cause. Psychogenic hyperventilation syndrome. This was the summary of previous class. Next, we will move on to the investigations. In investigations, in case of acute dyspnea, after ruling out upper airway obstruction, anaphylaxis, and pneumothorax, if these are ruled out, then the following should be assessed. Assess the level of consciousness, because if the patient is in type 2 respiratory failure, then his consciousness level will be low and he may require endotracheal intubation. Assess the degree of central cyanosis. Check whether patient is able to speak in single words or sentences. If he is not able, then it indicates severe breathlessness and he can progress into uh, type 2 respiratory failure. Type 2 respiratory failure. Okay. Type 2 respiratory failure. Degree of central cyanosis and ability to speak. This is first one. If he is not able to speak in one full sentence, then it is severe breathlessness. If his conscious level goes down, then he may be going into type 2 respiratory failure. Assess the work of breathing, check SpO2, check the rate, depth, pattern, use of accessory muscles, check the cardiovascular status, heart rate and rhythm, BP, and peripheral perfusion. Okay, so these things you should check in a patient of acute breathlessness. Most of the times, clinical history, examination, and chest X-ray, ECG, ABG. Many of the times today, nowadays, VBG is performed because ABG is painful and not everybody can do. So VBG is performed instead of ABG. So you can do VBG also. Chest X-ray, ECG, and VBG will usually indicate the primary cause. You can also use peak expiratory flow meter if you are suspecting asthma to measure the quantity of breathlessness. Quantity of breathlessness. And ABG will often provide additional information to SpO2 measurement alone, particularly if there is clinical evidence of drowsiness, delirium, asterixis. These are all indicating the patient is going in type 2 respiratory failure or a strong likelihood of hypercapnia. Okay, so a patient comes with acute breathlessness, acute onset of breathlessness. So for by history and physical examination, by history and physical examination, you have some provisional diagnosis provisional diagnosis. Treat that provisional diagnosis. Alongside with that, do chest X-ray, ECG, and VBG, and if bronchospasm suspected, PEF. Okay. provisional diagnosis, and you will reach a uh, specific diagnosis, then treat according to that specific diagnosis. This will be the algorithm for management of patient of acute breathlessness. So in history, physical examination, and examining the vitals of the patient, vitals of the patient. Okay, one important point: dyspnea with normal chest X-ray, where you will see. So dyspnea with normal chest X-ray, cardiac disease like coronary artery disease, ischemia, or massive pulmonary embolism, okay, or pulmonary hypertension, you will see normal chest X-ray. Respiratory disease like asthma, early interstitial lung disease, you can see normal chest X-ray. Metabolic disease like anemia and acidosis due to any cause, you will have normal chest X-ray. So along with along with chest X-ray, ECG, ABG, you can also measure NT-proBNP if you have doubt between if the cause is because of, whether the cause is because of a cardiac or because of pulmonary. So NT-proBNP is not specific. This is also raised in pulmonary embolism, acute exacerbation of COPD, pulmonary hypertension, and atrial fibrillation. But you can rule out or rule in the cause based upon uh, the levels of NT-proBNP. If the NT-proBNP level is less than 300 picogram per ml, that rules out cardiac cause of breathlessness. It rules out congestive heart failure. If the NT-proBNP is less than 300 picogram per ml, then there is no cardiac cause. 99% specificity. Age-related cutout points to rule in. That means there can be a cardiac cause. There can be a cardiac cause. So for patients less than 50 years, if the NT-proBNP levels are more than 450 picogram per ml, then there can be a cardiac cause. Cardiac cause can be there. And if the NT-proBNP is more than 900 in patients more than aging between 50 to 75 years age, that shows cardiac cause of breathlessness. In patients more than 75 years of age, more than 1800 picogram will indicate a cardiac cause of breathlessness. So if to rule out if in any of patient of any age, if the levels of NT-proBNP is less than 300, then that rules out the cardiac cause of breathlessness. And if there is any cardiac cause of breathlessness, then NT-proBNP will be less than 450 in patients less than 50 years of age. It will be 900 in patients aging from 50 to 75 years of age, and it will be more than 1800 double for 450 doubles to 900, 900 doubles to 1800 in patients aging more than 75 years of age. More than 1800 of picogram per ml of NT-proBNP will indicate a cardiac cause of breathlessness. Along with that, you will also have blood test you should order. So you will order RFT, LFT, electrolytes including calcium, magnesium, bicarbonate levels, glucose, ketones, lactate levels. Okay, these are the basic metabolic panel which you investigate along with radiological investigations like chest X-ray uh, and ECG and VBG, PEF. Along with those, you should send metabolic panel and NT-proBNP. So these are the more invasive investigations which you can do if there is you still don't know the cause of breathlessness. First one is HRCT thorax or CT angiography for any chronic for thromboembolism. Diffusion lung capacity for carbon dioxide and bronchoscopy. 2D echo stress testing can be done. Okay, these are advanced second line investigations which you can do in patient of acute breathlessness. First line investigation, to summarize: chest x-ray and ECG, VBG or ABG, VBG or ABG, this one. And you are suspecting, if you are suspecting asthma, PEF, NT-proBNP if you are suspecting cardiac cause. Along with that, basic metabolic panel which includes CBC, CBC, LFT, RFT, electrolytes, with calcium bicarbonate levels, also magnesium. Okay, electrolytes and RBS, sugar levels, lactate levels, and ketone levels to rule out the metabolic causes. Okay, so these are the first line investigation in case of acute breathlessness. Second line investigations are these. So any person with chronic breathlessness coming to you, you can quantify the breathlessness based on MMRC scale or New York Heart classification, modified modified medical research scale, MMRC scale, and NYHC scale. This is used for pulmonary cause and this is used for cardiac cause. Basically, these are used for chronic cause of breathlessness, chronic causes of breathlessness. See, so for pulmonary cause of breathlessness, MMRC scale, 0 is not troubled by breathlessness except with strenuous exercise. That means it is normal. 1 is shortness of breath walking on level ground or with walking up a slight hill. Walking on level ground will produce shortness of breath, or if he walks in up up slightly, then that is grade 1. Grade 2 is walks slower than people of similar age on level ground due to breathlessness, or has to stop to rest when walking at own pace on the level. This is very important. Second point, has to stop to rest when walking at own pace so here he will be walking with breathlessness on the level ground. Here he has to stop while walking on the level ground due to breathlessness. Stopping, taking some breath, and after some time he will wake up and again walk. Again due to breathlessness he will stop. So that is grade 2. Grade 3 is 100 meters you can't calculate. So this is more important. After walking a few minutes on the level ground, patient will stop and stops to walk after marking for a few minutes, and further he will not walk. Okay, so this is the grade 3. Grade 4 is he can't leave the house due to breathlessness, or he can't perform the daily living activities due to breathlessness, like dressing, undressing. All these will produce breathlessness. So 0 is strenuous exercise. 0 is strenuous exercise. 1 is walking on the level ground, walks but he will not stop, walks with breathlessness, or walking up a slight hill will produce breathlessness. Number 2 is walks on the level ground, has breathlessness, he has to stop for breathlessness. Again, after taking some breath, he will wake up. Number 3 is stops after few minutes of walking. Number 4 is breathlessness is so much that he is unable to perform the daily life activities. So that is about MMRC scale used to judge the severity of breathlessness in pulmonary cause. New York Heart Association classification of breathlessness. So this is used for cardiac cause. Cardiac cause. Class 1 is no limitation. Ordinary physical activity does not cause fatigue, fatigue, dyspnea or palpitation. Class 2 is slight limitation of physical activity. Comfortable at rest, but ordinary physical activity results in fatigue, dyspnea or palpitation. Okay, he is using these three: fatigue or dyspnea or palpitation. Class 3 is there is marked limitation of physical activity. Comfortable at rest, but less than normal activity produces symptoms. Here, ordinary physical activity produces symptoms. Here, less than ordinary physical activity produces symptoms. And in class 4, unable to carry out any physical activity without discomfort. Okay, so here are 4 stages from 1 to 4. Here 0 to 4. Okay, now this is a chart to for the evaluation of breathlessness. So patient gives history and examination. So based upon that history and examination, you will have some provisional diagnosis. In acute causes of breathlessness, you just give treatment for that and send the patient for those first line investigation. Then if cause is known, then treat that cause. If you don't know the cause still, then you can go to the second line investigations. So this chart is basically helpful for chronic cause of breathlessness. So first line investigations again here are walking oximetry and peak flow assessment. See here the first line. So these two will assess the severity of breathlessness. Actually, severity of breathlessness, severity of breathlessness, oxygen saturation and peak expiratory flow meter if there is asthma. Severity of asthma. So you are assessing the severity of breathlessness. So if you don't get diagnosis by history and physical examination, then you need the first line investigation for breathlessness. And what are those? Chest X-ray, ECG, spirometry, CBC, basic metabolic panel. Along with that, as we have learnt in acute breathlessness, VBG you can do and NT-proBNP you can do in acute causes. Okay, so these are the first line: chest X-ray, ECG, CBC, basic metabolic panel and spirometry. Again, if you don't know the cause of breathlessness, these are the second line investigations which you can do. So a general physician can go up to chest CT, up to here. Above that, like angiography, CT angiography or lung volumes, DLCO, or test for neuromuscular function, echo, cardiac stress testing, then the patient should be referred to specialist. Okay, still if there you don't know the diagnosis, consider cardiopulmonary exercise testing. So this is the very important step-by-step algorithm for investigation. So by history and physical examination, if you know, then treat. If you fail, then you just order the first line investigation. If you know, you treat. If you fail, you order the second line investigation. Okay, second line investigation are mainly done by specialists. So we can do chest CT, HRCT at least we can do, general physicians, but other investigation specialist will do. Now, so this is about how to investigate a patient with breathlessness. Last one is treatment. So how do you treat a case of breathlessness? The general treatment of dyspnea depends on the underlying etiology. Okay. In patients with acute hypoxemia, saturation is falling. Nowadays, pulse oximeters are available. Acute hypoxemia, start oxygen therapy Starting oxygen therapy is warranted even before establishing the cause. Just if the saturation is that's why first upon arrival only you check the severity of breathlessness. If the saturation is low, connect the oxygen either by oxygen mask or either by CPAP, BiPAP or intubation, depending upon the condition of the patient. Starting oxygen therapy is warranted even before establishing the cause. If patients are not hypoxic, there may be no role for oxygen supplementation. Okay. Avoid oxygen supplementation achieving saturation more than 94 to 96%. So you should adjust the machine so that the saturation does not go above 96 percentage. It should be below 96 percentage. Caution is warranted when administering oxygen to patients with chronic carbon dioxide retention. Yes. Example, severe COPD, asthma, interstitial lung disease, severe pulmonary arterial hypertension. In such situations, the goal of supplemental oxygen should be to achieve an oxygen saturation level between 88 to 92%. You should adjust the machine to have a saturation between 88 to 92%. Why? Because these patients with chronic breathlessness will have increased carbon dioxide, will be type 2 respiratory failure for a long time. So the body is dependent upon high level of carbon dioxide for normal level of respiration. So if you give more oxygen, carbon dioxide will level will come down. So because of type 2 respiratory failure, the threshold of the respiratory center is already raised because of chronic carbon dioxide retention. So if you give oxygen at a higher level, carbon dioxide will be washed out, and because of less carbon dioxide, there will be less stimulation to the respiratory center because the threshold is high. So patient will have decreased respiratory drive. That's why you should maintain the oxygen between 88 to 92. Patients with hypoxia, hypoventilation due to any cause, most commonly poisoning, opioid poisoning, or organophosphorus poisoning. Okay. Hypercarbia, type 2 respiratory failure. This is type 1 respiratory failure. May require non-invasive ventilation like CPAP or BiPAP. High flow nasal oxygen. Okay. HFNC we call it as high flow nasal cannula, HFNC. Okay. It can provide, I think, I don't remember properly, 10 to 15 liters per minute oxygen, HFNC. So any patient who is having hypoxia, hypoventilation, or hypercarbia may require NIV, non-invasive ventilation, like HFNC, CPAP, and BiPAP. Continuous positive airway pressure ventilation or bilevel positive airway pressure ventilation. So CPAP is nothing but apart from giving oxygen, you maintain the pressure when the pressure at the time when the patient is exhaling, so that because of that pressure, the airways are kept open so that oxygen can go to the air spaces properly. Okay, that is CPAP. In BiPAP, in CPAP, one problem is that the pressure will be constant during inspiration also and during expiration also, whereas in obstructive lung diseases, the airway will collapse during expiratory phase of respiration. So that is the disadvantage of CPAP, that the pressure will be maintained during inspiration also the expiration, uh, but we want pressure only during expiratory phase. So that's why BiPAP, bilevel positive airway pressure is given, where the machine will maintain pressure only during expiratory phase of respiration of the patient. In patients in whom NIV has failed or those who are unable to maintain their airway, endotracheal intubation and mechanical ventilation may be warranted. So this is the general treatment of breathlessness. Oxygen therapy should be given to every patient coming acute breathlessness patient, regardless of the cause. And in chronic respiratory failure patients, you should maintain the saturation between 88 to 92. And in acute hypoxic patient, you should not go above 96% saturation. And in any patient with hypoventilation or hypercarbia, they may require CPAP or BiPAP or HFNC, high flow nasal cannula oxygen, to maintain the saturation. Or some patient, if they don't maintain this saturation, then endotracheal intubation has to be done to give oxygenation. The time is already 50 minutes. I can't discuss the briefly. I will say in a respiratory system, mainly two diseases will treat: asthma and COPD. So basic treatment of this is asthma is LAMA, long acting muscular antagonist, and COPD, sorry, asthma is LABA plus inhalation corticosteroids, and COPD is monotherapy. If you are giving, then it is LAMA, and dual therapy if you are giving, that is LAMA plus LABA, long acting muscarinic antagonist with long acting beta agonist. That is the first line treatment. In cardiovascular system, if you are treating acute heart failure, then nitrates are the drug of choice. Nitrates are the drug of choice, which reduce the preload and afterload of the patient and reduce pulmonary edema. You can give giving it as infusion is preferred, but if there are some constraints, you can give it some sublingually also, 5 mg as 5 mg tablets, 3 doses 5 minutes apart you can give, monitoring the BP of the patient, and if a patient comes with chronic heart failure, then Lasix is the drug of choice. Sorry, furosemide is the drug of choice. And giving this in infusion is preferred. And if you can't give as IV infusion, you can also give this as intramuscular injections. Okay, that is the basic treatment. And in case of thromboembolism, it is massive, then you can thrombolize the clot. Thrombolysis can be done, or thrombectomy, removing the clot by surgery. You can do thrombectomy. Thrombolysis by alteplase, commonly, which is commonly antifibrotic, which is used is this one, alteplase. Okay, streptokinase can also be used. This is cheaper actually, streptokinase, and this is some costly. Thrombectomy is removal of the taking out the clot from that pulmonary artery by surgery. Thromboembolism, acute thromboembolism. Metabolic acidosis. In metabolic acidosis, treat the cause. If the in diabetic ketoacidosis, what you will do in diabetic ketoacidosis, you will hydrate the patient. Okay, main thing is hydration, and give insulin by infusion, or if not feasible, you can give insulin subcutaneously also, or intramuscularly also. I'm not going deep into that. And you should know before giving insulin in diabetic ketoacidosis, must know potassium levels, because if you give insulin with reduced potassium levels, insulin will further reduce the potassium level, causing hypokalemia. That's why first hydrate the patient, and before giving insulin you should need to know the potassium levels. Adjust according to that. Again, there is some procedure, not going to discuss that. In acute, again this is a metabolic cause, metabolic acidosis. Acute on chronic kidney disease, so you can give sodium bicarbonate. In chronic kidney disease, actually it is okay. In chronic kidney disease, in AKI you can give sodium bicarbonate as IV infusion, but you need to be careful because of risk of hypocalcemia. Okay, you can give IV this one, sodium bicarbonate. That is one. Okay, that's all. That was a brief treatment of specific things. So I hope you are learning. We are learning. I am also learning. You are also learning. So we are learning, and we are benefiting from these things. So we have concluded the topic of breathlessness by this. I hope you are enjoying this. And if any correction is required, please comment. Thank you.